Any questions you have, you can ask. It is always better to connect and ask, because right now, then if there are no questions, if you do not have anything, then we can move on to ductus venosus.
Ma'am, what else we have to see in this head area besides nasal tip, nasal bone, knuckle translucency, and diencephalon? The palate and how we assess the cleft palate and cleft lips
Okay, so
at this age.
we will do the structural analysis later during the presentation, or maybe in the second lecture that we do. Right now, your focus is on nuchal translucency, nasal bone, tip, diencephalon, and the correct positioning. How to see cleft lip, cleft palate will come subsequently. We will be able to
Ma'am,
do
that is
that
done
later.
in anomaly scan, or we assess it in early scan only? That 11
The
to 13 weeks we can assess, or we have to assess it at 20 weeks around?
So cleft lip, we prefer doing it later, but cleft palate, we also assess in the structural analysis in 13-week scan, what we are doing right now. So in this, we do look at the palate, because it is the one of the structures that we start assessing from 12 weeks onwards. So we should look at that. But cleft lip, if we are talking about structural, that we usually see in the second trimester anomaly scan. Dr. Mamta is asking, please tell the probe movement. All the videos of our live cases are with Mr. Sultan at the Iqramed Academy. You can always join those lectures and see that how what I am talking and telling you right now. We all those videos are with the lectures are at Sultan's Iqramed Academy. You can always join and see. Yeah, another question is anything to turn from prone to supine. See, you cannot do anything much except gentle movement with your probe for on the patient's lower abdomen, but usually try not to do too many things, too much pressure. Putting pressure on patient's abdomen can be very discomforting, and the patient loses the confidence of coming back and getting an ultrasound done. It should be an experience and not something which the patient dreads to get it done next time. However, if you have seen the patient 2-3 times and you tell them that, okay, pass urine and come, or hold urine and come, or eat something sweet and come, you have done all of that for 15, 20 minutes, half an hour, then it is important that you do a transvaginal ultrasound, because sometimes if you are seeing the fetus and the fetus is continuously in the prone position, then when you are doing a transvaginal ultrasound, then the orientation changes and the nuchal translucency is clearly seen, and in fact it is better seen, but it can be uncomfortable and for the patient. But at the same time, you can always try that. If the fetus is not moving, you try and do that. Another question, I'm addressing the questions right from the top, and I'm happy a lot of doctors are asking how to get sagittal view probe movement. So, if you look at our lectures, the probe movements are very clearly explained. That if you are holding the probe like this and you are keeping it on the patient's lower abdomen, it will give you a horizontal image. Now, you turn the probe 90 degrees and it will give a sagittal image. However, these probe movements are better seen practically in the videos, and which Sultan has and Mr. Sultan you can always get in touch with him. What should be done if the nuchal translucency is found to be increased? As I have told you in the slide, if the nuchal translucency is raised, then first and foremost is that how much is it raised? Is it within the 95th percentile or is it over that? If it is higher than the 95th percentile, then definitely this is a problem. Then you have to assess it carefully. So once you have charted it and you know that it is higher, then number one thing you have to rule out is chromosomal abnormalities. You will do the structural analysis also, and you will send the fetus, depending on the gestational weeks, for amniocentesis, NIPT test, and other biomarkers for the assessment of the chromosomal abnormalities. Does fruit juice help? Yes, it does, but make sure your patient is not diabetic. In gestational diabetes, we try and avoid giving sweets. We try to give them hot liquids or warm liquids and try and see that the fetus moves. But yes, eating definitely helps. We are using 3.5 to 5 megahertz curvilinear probe. I prefer using that probe. That is the best probe, and you should use that. 3.5 to 5 megahertz is a good frequency for the convex probe to be used for NTNB. Normal curvilinear probe, yes, normal curvilinear probe we use. 3D probes are more effective when you have to take 3D images and do a mid trimester, the second trimester normally scan. Then the 3D probe is useful because you do the 3D assessment of the face, the mid face and all. I don't see any other questions. Are there more questions or should we start with the? So investigation of choice for this, for what? Investigation of choice for this is investigation of choice for what? For nuchal translucency you're talking about? Yes, of course, ultrasound is the investigation of choice. Okay, for ductus venosus, yes. For ductus venosus, it is the best to assess it on ultrasound. The vessel can be identified because it has a characteristic aliasing, and it is easier in the first trimester sagittal view. We look at the ductus and it very easily comes. In the second and third trimester, we take the axial view of the abdomen and it comes because it's again aliasing, so we can assess it and it gives us appropriate information.
What is focal? You are telling focal about something.
The focal point on the screen. So if
Yeah.
you see in many of our lectures, we have also mentioned this, that when you are looking at the screen of the ultrasound, the screen where you are recording, on the left hand side of the screen, there is a focal point that comes as a small arrowhead.
Okay.
And that arrowhead you can adjust. So where you want your ultrasound rays to be focused, you should put that focal point there. It can be a 2 point, it can be a single point. So that gives us a better view of the, like all the rays are there, so we do not get reverberation artifacts, especially in nuchal translucency. When the ductus venosus assessment is difficult, what alternatives or repeat scan options are available? See, in first trimester or early anomaly scan, there is no way that we cannot assess ductus venosus. We have to call the patient again. Our scan will not be complete unless we see ductus. It is very, very important. So in every case, you will have to assess. If you are not able to see it through the transabdominal probe, do a transvaginal ultrasound to see. But try and see it. Make the patient wait for some time. And you will, even if the fetus is prone, the good part is that even if the fetus is prone, you can still take ductus venosus because all we need is sagittal position. It is not necessary sagittal supine. The fetus can be sagittal prone also.